Welcome to Stat, I'm telling you all medical true crime stories, and it gets bizarre. Karen Wickham, yeah, she used to work in ER, and now she's sharing the knowledge, so let's get involved. Hey, funny and scary at the same time. Medical mysteries, all facts, she ain't lying.
No, I'm not.
So tune in to Stat if you dare, cause crazy things can happen anytime, anywhere. Yeah.
So true. Hello, everybody out there in podcast land. Welcome to Stats, Shocking Traumas and Treatments, and I am your host, Garrett Wickham, coming to you from beautiful Toronto, Ontario, Canada. And of course, the lovely Mary.
Yes, hello.
Is here.
Good day.
Today.
Good morning. Good afternoon. Good evening.
Yeah. You know,
wherever you may be, at whatever time you may be.
You are a big part of Stat now.
Thank you.
Not just having to deal with me behind the scenes, having my temper tantrums over the horrible human beings that I cover, but yeah. Anyway.
Well, I try to keep you balanced.
No wonder you look exhausted at the end of the day. Okay, so today we're going to cover the uterus. I know I started on the uterus in the last episode, but the uterus, there is just so much to cover for this little, less than fist-sized organ in our female bodies. This thing has a lot going on with it.
So, yes. So
a lot can go right. Like
so miraculous.
Yeah.
Mm-hmm.
A lot goes right with the uterus. I mean, babies, you know, but a lot can go wrong with the uterus, unfortunately. So, because it's regulated by basically hormones. And we are going to get into this. So I'm pretty much, this whole episode is going to be dedicated to the uterus.
So
I love you, girl. I'll miss you because I don't have one anymore. I don't know if I miss it so much. You know, when I was, after I had my hysterectomy, I was 37. I know, young, but it was the best thing I ever did because, you know, I was really suffering a lot with it. And so true to Karen, I hate speaking about myself in third person, but anyway, while I'm recovering, I write this song called My Uterus. And my son was an accomplice. He was 16 at the time. That boy put up a lot. Like he was a good sport to have a mother like me. So, you know, when they're at that age and like get so embarrassed, he actually didn't get embarrassed by the shit. He just got sick and tired of like, you know, doing stuff with me. Anyway, so he played guitar in this song, and I have the video somewhere I've got to find, but I called it My Uterus, and it goes something like this. My uterus, I hate you. My uterus, how could you do this to me? And then there's all these lyrics, and it ends up with this. My uterus, my uterus, my uterus, ah! Like, that's how it ends.
That sounds like a typical song for you.
See, I've been doing this stuff for a while, so I got to find the video. He's a good sport, good kid, sitting with his mother singing about uteruses. Anyway. Now that I've got that out of my system, let's talk about this thing, this organ. So I'm going to start off with prolapse. And what is this? Well, the uterus is held into place inside your pelvis with various muscles, tissues, and ligaments. And when they can no longer hold it in place, there are 4 degrees of prolapse. Now, remember when we discussed the uterus, the lowest part of it is the cervix. So a first degree is when the cervix drops into the vagina. Second degree is when the cervix drops to the level just inside the opening of the vagina. Third degree is the cervix is outside of the vagina. And the fourth degree is the entire uterus is outside of the vagina. And it has zero support, basically, from supporting muscles. Now, I've seen this. Working as a new nurse, I was shocked. I didn't know what to think.
That thing hanging out there.
Yeah, it's quite significant when you see it. It's like Yeah, it's like a punching bag in between your legs.
Well, giving birth is like a punching bag between your legs.
It's more than that.
I mean,
But I mean, I was just like, oh my God. And
this really happens.
it does. And I wasn't quite sure at first because actually I say new nurse, I was in school and I thought, oh my God, this poor woman has like terrible cancer. And anyway, it wasn't that. It was her, she had a prolapsed uterus and that's why she was in the hospital. It was to get a repair. So anyway, yeah, it's quite shocking and uncomfortable. And we're going to talk about, that.
So basically, the supporting structures just weaken through birth trauma, probably.
Yeah, I'm going to go over the conditions that can cause this.
Okay.
So one of them is a connective tissue disorder, like rheumatoid arthritis, Marfan's, lupus, or Ehlers-Danlos syndrome. Okay. Other conditions that are associated with the prolapsed uterus can be a cystocele, which is a prolapsed bladder. So there's a herniation, bulging of the upper front vaginal wall where a part of the bladder bulges into the vagina. Then you have the enterocele, which is a herniation of the upper rear vaginal wall where the small bowel portion bulges into the vagina. And when someone with this stands up, they get a sensation of like get a backache and they feel like something is pulling on them. And when they sit down, they feel much relief from that. Then you have the rectocele, which is a herniation of the lower rear vaginal wall where the rectum bulges into the vagina. And this makes bowel movements difficult to the point where you may need to push the inside of your vagina to empty your bowel. So these are different from a prolapsed uterus, but you can have this with it because of the problems with the muscle and ligaments and stuff like that. So now here are the symptoms. You have a feeling of fullness or pressure in your pelvis, and it may feel like you're sitting on a small ball when you sit down. Low back pain, feeling like something is coming out of your vagina, painful sex, difficulty with urination or moving your bowels, and discomfort walking. Now, this can become a medical emergency because it can obstruct the bladder or bowel to the point that you can't pass urine or bowel. Okay, because it's just pushing so hard. And that's a medical emergency because you get a large bowel obstruction or your bladder just fills to the point that you can't pass urine or stool. So the causes and risk factors for this: pregnancy, childbirth with normal or complicated delivery through the vagina, weakness in the pelvic muscles with advancing age, weakening and loss of tissue tone after menopause and loss of natural estrogen, conditions leading to increased pressure in the abdomen like a chronic cough, straining, pelvic tumors, and accumulation of fluid in the abdomen like ascites. Being overweight, major surgery in the pelvic muscles, and smoking. So how do they diagnose this? Ultrasound, MRI, physical exam where you will stand, lie, and sit. Well, you can't sit, but stand and lying while coughing, and they'll feel what happens then if it pushes through. And ureteral obstruction. So what they'll do is they'll put an intravenous IVP pyelogram or do a renal sonography. So they will look to see if there's an obstruction in the ureter and, to what degree. Because if you think about it too, urinary tract infections are huge because you can't pass the urine. And just the area and the blockage and the lack of flow and natural bacteria, that kind of stuff, is just not able to work the same way. So infections are a big deal. So how do you treat this? Well, first of all, Kegel exercise. Kegel, 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 Kegel. If you're sitting right there, listen, Kegel.
All together now.
1, 2, 3. Give me a K. Give me an eagle. Kegel. Medication, estrogen, because there is not enough estrogen. surgery, hysterectomy, or a pessary, which is sort of a mesh support that's put into place to sort of hold it up.
Little like it's like a little what's the word I'm thinking of?
Well, I know as I'm making a cupping motion with my hands.
It's like it's basically like a little hammock.
Yes,
for your uterus.
It is a uterus hammock. That's exactly it.
Oh, hammocks are so comfortable. Just to lie in.
I feel like I'm in the Caribbean.
There you go.
Oh, now I have to draw a uterus in a hammock.
Yes, you do.
Oh my God. Okay,
That's gonna be a good
Give
one.
me such great ideas. Okay, so that's it for prolapsed uterus. Next, we're going to move on to fibroids, also known as myomas
Oh, I know that one's not easy.
and leiomyomas.
Just say fibroids.
Yeah, I know,
easier.
but sometimes you'll hear the medical term, and that's what they're known as. Okay,
Yeah.
These are non-cancerous growths that happen to women in their childbearing years. They range in size from tiny to big, bulky masses. They can be single or multiple. Multiples can expand so much that the masses can reach to the top of the rib cage and weigh quite a bit.
Yeah. My eyes just got really big. You couldn't see that, but I was like,
Yeah. What? It's not uncommon, and many women may have some fibroids and not even know they have it. They're asymptomatic. And don't cause them any problems. And oftentimes they're found incidentally during routine exams or prenatal exams. So here are the symptoms. And of course, they're dependent on the location, size, and number that you have of them. So most often that you have a heavy menstrual period, periods lasting longer than a week, pelvic pressure or pain, frequent urination, difficulty emptying the bladder, constipation, backache, or leg pains. But oftentimes they don't cause pain at all. So there are 3 types of fibroids. There's the intramural, which made me laugh because I think about,
intramural
running.
sports?
Yeah. They grow in the muscular uterine wall. Then there's submucosal, and they bulge into the uterine cavity. And then there's subserosal, that project outside of the uterus. So
They all sound nasty.
yeah. So if let's say like a time to go see a doctor is and you should anyway, but you have a pelvic pain that doesn't go away, overly heavy, prolonged, or painful periods, spotting or bleeding between periods, difficulty emptying bladder, and anemia. Now,
That's a big one, yeah, for some women.
one of my exes had a huge fibroid. And we knew that she had a heavy periods, but that seemed to be the case that she'd had for most of her,
I've heard
most
this
of her
before,
years.
yeah. Just like, oh, my whole family's like that or whatever.
Yeah.
Everybody. My mom was like that.
Yeah, and she, had, she was one of those people that you could cut her leg off and she would just be like, oops. Like it didn't, like, incredibly high pain threshold, and just didn't really, complain about much.
Or just thought that was normal for their period, right?
And so one day we had come back from somewhere, and she was just lying on we had gone to the beach, and she was lying on the bed in her bathing suit. And I saw that her lower abdomen was had a huge bulge in it. Like, she looked probably 3 or 4 months pregnant. And I don't know how I didn't notice it before, but I mean, you don't really just look at someone lying down, and it's just one of those things that didn't really notice. And I was like, what the hell is going on with you? And she's like, yeah, as per usual. So an appointment was made with a gynecologist, and as it turned out, she had a huge fibroid. And also too, she was really anemic, but she had been anemic for a long time. So she'd go get routine blood work done, and always anemic, was taking iron supplements, all that kind of stuff.
I wonder why.
Yeah, and so had had a hysterectomy, and felt so much better afterwards. But I just remember the shock of going, whoa, what is that? But I guess what had happened is it had been growing. And so it wasn't noticeable until it was like, you just get used to how someone looks until all of a sudden you go, whoa.
Well, and if you're lying a certain way, like if you're lying and you're kind of laying back, but your legs are hanging over, like it'll expose things more kind of thing.
It was just like shocking. Anyway, thank goodness it turned out that that's what it was. And she was able to get treatment for it. And she had no problem with the hysterectomy. Never was going to have children, that kind of thing. So, yeah. So that is, those are the symptoms. Now, causes. They're not totally sure.
I had a client who had a fibroid, and they knew that's what it was and stuff because she wasn't pregnant and whatever, and had all the symptoms and stuff. She was getting examined, like the doctor was doing like a external palpation, feeling around and stuff, and he's like, 15 weeks, and the nurse.
What?
And she looked at the nurse. She's like, "What?" And he left. And she's like, 15 weeks? What do you mean? Like, and she goes, "Oh, like if you were pregnant, then that would be about where you were. If this was a baby, it would be the equivalent of 15-week pregnancy."
Oh, he didn't say she was pregnant. He was just like,
no,
yeah,
she knew she wasn't
this
pregnant.
Sucker is about the size of 15 weeks. Oh my goodness, that's funny.
That's how he like measured it basically
by size,
which
of
is pretty significant.
I guess. Well, yeah. The thing is, they're not sure what causes it. So they believe that there's a correlation to some things, but they're not 100% sure what causes it. So genetic changes in your body that lead to this happening. Hormones, so estrogen and progesterone, they play a massive part in every woman's life. An imbalance in that can be like, well, it causes a lot of our problems.
Those dang hormones.
So an upset in that increases the growth of the fibroids. Fibroids contain more estrogen and progesterone receptors than the uterine cells do. So the actual fibroid is like surviving and sucking up the estrogen and progesterone in the body.
It's like a alien baby inside there.
Fibroids most often shrink after menopause because of the decrease in estrogen and progesterone. The other thing is called extracellular matrix. And it's material that makes the cells stick together, and it makes it fibrous. So they're thinking that there may be something going on with this. Also, stem cells. Stem cells develop in the smooth muscular tissue, and it divides repeatedly, creating a firm, rubbery mass. And so, yeah, and they can grow at different rates. Some go through growth spurts.
It sounds, it's like, it's a bouncing baby fibroid.
Yeah, like it's gone through a growth spurt. I guess that's what happened with my ex. Anyway, many fibroids that are present during pregnancy can shrink and disappear after pregnancy. So what are the risk factors? Black women are more likely to have more fibroids at a younger age, and they are usually bigger and more painful than women of other races. Heredity, it can run in the family. Other factors, like having your period early in age, obesity, vitamin D deficiency, and drinking too much alcohol. Complications, discomfort, anemia, fatigue, that's what we talk about it. And some women are so anemic that they will need a transfusion.
Mm-hmm. Yeah, it was interesting about the vitamin D one. I discovered that in the last little while through work. I had sort of an interesting, sort of, not a coincidence, but I had a bunch of clients that had fibroids and infertility issues and endometriosis and stuff. And it was interesting because it was actually the woman who had the 15-week-old fibroid. And she said, I read something once. It was about longing for the home country, and which was kind of an interesting take. But she's South Asian descent. A bunch of the other clients were Palestinian, so Middle Eastern, South Asian, Latin America. So all countries where they would normally, if they were living in that country, absorb more vitamin D from the sun. So it was an interesting correlation. That's what I was looking for.
Yeah.
That I had these clients and I was like, And then I talked to the naturopath, and she told me a lot about the importance of vitamin D and et cetera, et cetera. But yeah, and it was crazy. It was like, okay, this makes sense now.
That's really interesting.
Yeah,
definitely.
So, and there was, I think a bit of a family thing, because the one I've treated like 4 of the 5 daughters.
Oh my goodness. So that definitely runs in the family, unfortunately.
And also too, some of them were like, at first didn't know, is they all had crap periods.
Again, you would go, oh, that just is, my mom was like that, my grandmother was like that,
but
kind of stuff.
Generally periods are not supposed to be so bad that you have to take Percocet.
Yeah. In fact, I remember you and I having a conversation. I'm like, how are you with yours? And you're like, well, didn't really hurt at all. Just, had it in that way. And I'm just like, my God, I am so envious of that. But again, in my family, it ran generation and generation on my mom's side. It was like everybody had shit periods, and it was just like, okay, well, unfortunately, you have that too. Mm-hmm. And you don't talk about periods, all right? Mm-hmm. Generation after generation going backwards. It's just something you sort of keep to yourself, or it just wasn't discussed.
Let's talk about periods. Let's talk about uteruses. All
right, that's a good one, Mary.
Do you like it?
Yeah.
Thank you.
So how do they diagnose these? Ultrasound, and unfortunately, transvaginal. Our favorite type of ultrasound, right, ladies? Not.
It's like our female equivalent of the prostate exam.
Lab, CBC, looking for anemia, that kind of thing. MRI. The other thing that they can do is called a hystersonography, where they inject saline into the uterus, have it expand, and then they can get a better vision of how many fibroids, what kind, that kind of thing.
Oh, your little fibroid babies in there.
Yeah. And then there's hystersalpingography. Hystersalpingography?
If you say so.
It uses dye to highlight the uterine cavity and fallopian tubes on x-rays. And then you have your hysteroscopy. Hysteroscopy. A small lighted telescope called a hysteroscope. Hysteroscope. It's got that damn O in there. That's throwing me off. Anyway, they go in and they look through the cervix into the uterus and take a look around and see what they can see.
Okay. Like a little mini drone that just goes.
Oh my God. You're on today, Mary. Treatment. So one of the treatments is called watchful waiting. Let's just wait and see what happens. But, follow-ups, but still. Medication. One is called the gonadotropin releasing hormone, and it blocks the production of estrogen and progesterone. So it puts the woman into a state of menopause. The fibroids shrink and the anemia improves. And it's usually for a 3 to 6 month long period of time, because you're in menopause before you're supposed to be, and all the things that happen because of that, such as bone loss. So you don't want to use this long term. Progesterone releasing IUD. It relieves heavy bleeding from fibroids and symptom relief, but it doesn't shrink the fibroid. And the next one is tranexamic acid.
Ow. That sounds painful.
It's a non-hormonal treatment that helps with heavy periods, and it's taken on heavy period days. Okay?
Oh, I see. That kind of acid. All right.
So there's
some like LSD acid.
Jesus, your uterus on acid. I don't like the thought of that.
Well, that's another one you got to draw.
Yeah, uterus on acid. Oh my God, I could just do a whole
uterus
series
on acid in a hammock. Oh.
I could do a whole cartoon series of the wandering uterus. Mm-hmm. That's an idea. Okay, non-invasive treatment. So you can have an MRI where they use sound waves, and they heat and destroy small areas of fibroid tissues, but it's really not used that much. I've never heard of it. Then there's minimally invasive procedures, and one of them is a uterine artery embolization. So they use embolism agents, or embolic agents are injected into the artery supplying the uterus, and it cuts off the blood flow to the fibroids, causing them to shrink and die. But the problem is that the blood supply could be cut off to the ovaries, fallopian tubes, and other areas around there. So that's something that needs to be used very carefully. Then there's radiofrequency ablation. They use radiofrequency energy that destroys uterine fibroids and shrinks the blood vessels that feed them. And that usually is done laparoscopically, but it can be done transcervically.
That sounds
it's similar to like freezing.
Okay.
Okay. And so basically,
It reminds me of
cryo stuff where they would go in and just,
freeze it. That reminds me of the woman who scared away a cougar that was tracking her by playing Metallica on her phone.
What? Where did that come from?
Radio frequency.
Oh my God. So this Canadian woman in like figure is inside of her uterus playing Metallica to make sure where did this come out of your brain? You're too much like me today.
I was thinking about, you were saying like radio frequency, and I was thinking, let's put some heavy metal in there and just shake those fibroids out of there. But no, there was a woman who was being stalked by a cougar.
Yes,
and she
blasted Metallica.
That's Metallica, and it ran away.
Yeah, that's a Canadian way of dealing with things. Okay, so there's a laparoscopic or robotic myomectomy. So basically the surgeon removes the fibroids, leaving the uterus in place. You have a hysteroscopic myomectomy for submucosal fibroids, and they remove them by going through the vagina in to the cervix and up into the uterus. Then there's endometrial ablation, which is a specialized surgical tool inserted into the vagina, into the uterus, that uses heat and microwave energy, hot water, or electrical current to destroy the lining of the... I wrote universe.
Oh, no. That would be bad.
I must have gotten distracted when I was writing that. The lining of the universe. The lining of the uterus. But it ends the period or reduces menstrual flow. It doesn't remove fibroids outside of the interior lining of the uterus. And the person that gets this is unlikely to get pregnant afterwards. And it must be done with the thought that you could have an ectopic pregnancy if you were able to get pregnant. And then you have your traditional surgical procedures. Abdominal hysterectomy, okay, for multiple fibroids that are very large and very deep. Previously, hysterectomy was the only option, but of course, a woman is sterile after that. But if the fibroids are so huge, she's not going to get pregnant to begin with. So, yeah, that's basically what you're looking at for treatments. So,
So they suck, basically.
Well, little ones, they can come and go, and it's when they turn into many big suckers that it becomes a big problem. So, yeah. Okay. The next thing we're going to talk about here is endometriosis. This is an incredibly painful condition. Some women don't have too much pain with it, but that is rare. Okay, so let's go over what endometriosis is. The inner lining of the endometrium builds up over a month and then sheds when the woman doesn't become pregnant. However, the tissues that are similar to this, that build inside the endometrium, grow outside of the uterus. And this can involve the ovaries, the fallopian tubes, and tissue lining the inside of the pelvis. Now, the tissue acts exactly like it would inside the uterus, is that it thickens, breaks down, sloughs, and bleeds. And it has no way to exit the body. Therefore, it becomes trapped. If it involves ovaries, the cysts are known as endometriomas, and the surrounding tissue can become irritated and eventually developing scar tissue and adhesions. And these adhesions can cause pelvic tissues and organs to stick together. So what are the symptoms? Painful period, pelvic pain and cramping, lower back pain and abdominal pain before, during, and after the cycle. Painful sex, pain with bowel movements or urination during your menstrual period, excessive bleeding during and between your periods, infertility. Endometriosis is often first diagnosed when investigating infertility. And other symptoms are fatigue, diarrhea, constipation, bloating, nausea, especially during periods. Now, these are non-specific symptoms because you can relate them to other things. And like I said, pain may not be a symptom because some women have severe advanced endometriosis and little pain, and others have, not as bad but have extreme pain. And oftentimes it's mistaken for other conditions such as PID or IBS, so pelvic inflammatory disease or
irritable bowel.
Yeah. So here are some of the causes. One of them is called retrograde menstruation. So this is when menstrual blood containing endometrial cells flow back through the fallopian tubes and into the pelvic cavity instead of out of the body. So they go backwards or flow up. The cells stick to the pelvic walls and the surfaces of the pelvic organs, and it grows and thickens and bleeds through that cycle. Another one is called transformation of peritoneal cells, also known as the induction therapy. Hormones or immune factors promote the transformation of peritoneal cells. So the cells that line the inside of your abdomen turn into endometrial cells. They're not sure how it happens, but they feel that is possible or a possibility. The other is embryonic cell transformation, where hormones like estrogen may transform embryonic cells into endometrial-like cells and implant in different areas of the pelvic cavity, and this usually happens during puberty. Surgical scar implantation. So they're thinking that maybe you have a C-section and endometrial cells, attached to the surrounding areas, and the surgical incision causing it. Endometrial cell transplant, where blood or lymph fluid may transport endometrial cells to other parts of the body. And maybe an immune system disorder that makes the body unable to recognize and destroy endometrial-like tissues that are growing outside of the uterus. So a lot of ideas, a lot of thoughts. Some of them kind of creep me out. Yeah. It's just these traveling endometrial cells going, I'm going to implant here, and I'm going to make your life miserable.
Yeah, they're like little renegades. They're just like, we're out of here.
Yeah.
See ya. Gonna go explore.
So the risk,
greener pastures.
Yeah. Jesus, Mary, I love your energy today. Risk factors. Never giving birth. Have never given birth before. Starting a period at an early age or going through menopause at an older age. Short menstrual cycles that are less than 27 days. Higher levels of estrogen in your body, or a greater lifetime exposure to estrogen that your body produces. Low body mass index, family history, and other disorders of the reproductive system. Complications. The big one, infertility. That's the main complication. Endometriosis may obstruct the fallopian tube and keep the egg and sperm from meeting up and turning into a human. And there's this thought that it's possible that this may actually somehow damage the egg or sperm, endometriosis, the cells, that they can be damaged by this condition. And women with mild to moderate endometriosis may still conceive and carry a pregnancy to term, but they're usually advised to have children earlier than later in case it progresses. And as for cancer, there's no real correlation with endometriosis and cancer.
I thought of another complication besides infertility.
What?
Pain.
Yeah, that's a big one. The fifth vital sign.
Pain, just misery. I've had so many women. Anemia, of course, would be one, but I've had so many women who just endometriosis and just pain.
That's what I had. That's why I got a hysterectomy. I was like, not dealing with this. Get it out. Among other reasons. I already had my baby. Okay, the next thing we're going to talk about is Asherman syndrome. It's a rare condition where scar tissue builds up inside the uterus, and it creates less space inside the uterus. And it's an acquired condition caused by either surgery, different types of surgery like a hysteroscopy, D&C, C-section, pelvic infections, cancer treatment for the cervix. But one thing that's not indicated in this are IUDs.
Now, I wonder if I had a client who never got a period. So she, got to about 16, 17 or whatever, or maybe earlier than that. And her mom was like, this is not right. And she had something like this, except it was already there. Like her uterus was just full of scar tissue. So I don't know if it's related to that syndrome. I'm going to look it up, but
I don't know.
And she said the name of it, and I wrote it down, of course, somewhere. But it's an interesting. So she basically never got a period, and her uterus is just full of scar tissue. So
that's awful.
Yeah, it's not a.
Well, to find out that you can't have children, that's.
I mean, I think it's very rare.
Yeah, I'd like to know more about that. See if you can find out what.
I'll see if I can find something and put it in the notes.
Yeah. One thing they do know is that it's not genetic because it is acquired. So the symptoms that you may have are light periods or no periods, severe cramping or pelvic pain, difficulty getting or staying pregnant. Because you can imagine that they may have a miscarriage or a stillborn because the baby doesn't have room to grow with all the scar tissue and thickening inside there. And the diagnosis is, like usual, ultrasound, hysteroscopy, saline infusion sonography. And the treatment basically is they want to relieve the pain associated with it, restore normal periods, and help the woman to get pregnant. So that's Asherman syndrome. Next, we have endometrial hyperplasia. The lining of the uterus, the endometrium, becomes unusually thick due to having too many cells. And this raises the risk of developing endometrial cancer. It's pretty rare. 133 out of 100,000 women will get it. Risk factors. Tamoxifen, which is a breast cancer treatment. Diabetes. Early age menstruation. You'll find that it's the same sort of symptom, risk factors or causes for all these conditions. Early age menstruation, late onset menopause, family history of ovarian, uterine, or colon cancer, gallbladder disease, hormone therapy, never getting pregnant, obesity, polycystic ovary syndrome, smoking, thyroid disease, being Caucasian, long history of irregular or absent menstruation. Now, there are two types of this. You have your simple, normal-looking cells that aren't likely to become cancerous. And then you have your simple or complex atypical cells that can lead to cancer. Okay, cause. Women who produce too much estrogen and not enough progesterone. So a normal cycle is when, ovulation, estrogen increases, the endometrium thickens, the progesterone prepares the uterus for pregnancy. No pregnancy, progesterone drops, triggers the uterus to shed its lining. But with this, you're making little, if any, progesterone, and the uterus doesn't shed its lining. It continues to thicken and grow. So the symptoms: abnormal periods, short cycles, unusually long periods, missed periods, bleeding after menopause. So they diagnose it with the same tools: ultrasound, biopsy, hysteroscopy. Complications: anemia, abnormal or heavy bleeding when it does shed, and cancer. 30% of women who don't get treatment will develop uterine cancer.
That's a pretty significant percentage.
It is. Okay, treatment: oral progesterone, a progesterone-releasing IUD, injections of Depo-Provera, and the outlook is good with progesterone treatment. So that's that. Next, we're going to move on to retroverted uterus, also known as the tilted uterus. So it is a uterus that curves in a backward...
Made me think of the tilt-a-whirl. Whee!
Oh my God.
Do you want to go faster?
How are you guys enjoying Mary today? This is a side of Mary that you guys don't see. I get to.
I'm a cheeky growl sometimes.
No, I love it. I love it when you're all silly like this. It's awesome.
The old tilted uterus.
Yeah.
Come and take a ride.
You should be doing the writing for my uterus comic. Okay. So it's a uterus that curves in a backward position at the cervix instead of a forward position. And then you also have something called the anteverted uterus, in which it tilts forward rather than backwards. But we're going to talk about the retroverted uterus. Symptoms. Some experience no symptoms. Those that do will feel pain in the lower back during sex, pain during menstruation, trouble inserting tampons, increased urinary frequency, feeling of pressure in the bladder, UTIs, mild incontinence, and protrusion of the lower abdomen. Causes. Genetics. Born with it. Endometriosis. The scar tissue or adhesive scars can cause the uterus to stick into a backwards position, almost like gluing it in place. Fibroids can cause the uterus to become stuck or misshapen or tilted backwards. Pelvic inflammatory disease. Again, the scarring. Similar to endometriosis. History of pelvic surgery. Scarring. You see there's a theme here. Previous pregnancy. Ligaments holding the uterus in place become overly stretched during pregnancy and stay that way. And this may allow the uterus to tip backwards. So let's talk about retroverted uterus and fertility. So a retroverted uterus doesn't usually affect the ability to conceive unless it's caused or complicated by other conditions. Okay? And this is treatable and correctable through minor surgery. So things like endometriosis, fibroids, PID, they complicate this further. So you get pregnant. What are you going to experience? So it doesn't usually affect the viability of pregnancy. Your first trimester, it can create more pressure on the bladder. It can cause an increased incontinence or difficulty urinating, back pain. Uterus at this point, though, should expand and straighten towards the end of the first trimester. And between 10 and 12 weeks, the uterus will lift out of the pelvis and no longer tip backwards. But it may not be able to make the shift if it's caused by adhesions that keep the uterus stuck into the pelvis. And this is called an incarcerated uterus. And if that's the case, you have an increased risk of miscarriage. When discovered early, it can be fixed, reducing or eliminating miscarriage risks. So let your doctor know if you're having a consistent inability to urinate or have pain in your stomach or near the rectum, constipation, incontinence, and these all are symptoms of an incarcerated uterus. So you get into the third trimester. It shouldn't be a problem at that stage, like we said, because the uterus should be sort of forced back into its normal position. And how the best treatment for this? Well, exercise. Kegel, 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 Kegel.
Everybody Kegel.
Are you Kegeling right now, Mary?
Yes.
I'm Kegeling. Too much information. I want you guys all who are listening to this on the count of 3, Kegel. 1 and a 2 and a 3 and a...
Kegel.
What does a Kegel sound like? Okay, we're going too far.
I'm still stuck on the incarcerated uterus. I've got a cartoon for that too.
Oh, God. It's going to be behind bars, right? Yes. Okay, so Kegels, knee to chest stretches, and pelvic contractions. So just, squeeze. If it's incarcerated, pessaries may be put in place, like we talked about, that will prop up the uterus. But you can't have that permanently because it causes an increased risk of infection. And the outlook? It rarely infects your fertility, like we said, or pregnancy unless it's associated with another condition. All right, we're going to talk about congenital uterine anomalies. So these are defects of the uterine development and shape that occur during intrauterine life. I found this really interesting because it gets into the physiology, biology, anatomy of things. So I didn't really know about this, and so it's kind of cool. It was a learning experience for me. Okay, so less than 5% of all women have this, but a quarter of women who have had miscarriages or preterm deliveries have had such defects as this. So this is where it was a big learning experience for me. The female organs develop in the Mullerian ducts. So these are a pair of organs that are there in intrauterine life to help develop. And each produces half a uterus and one fallopian tube. As time goes on, they fuse together to make the uterus whole with two fallopian tubes on each side. So the interruption of this normal development leads to abnormal uterine development and defects in the mature uterus. So there's different types. You have the septate uterus. So it looks completely normal on the outside, but it is separated on the inside into two different valves by a septum of varying size and thickness. So you have two endometrial cavities, and it's the most common.
Yeah, I know I had somebody who had that.
And it's 45% of the cases of this have it. So basically this is where you'd hear, oh, this woman has two vaginas. Okay, doesn't really have two vaginas. Okay, then
it's a bifurcate vagina.
Well, the next one is bicornuate.
Oh, okay, I was close.
It's an external indentation or groove can be found on the outside of the uterus, and then there's a division internally into two endometrial cavities. Two halves of the uterus may appear almost completely separate except for the lower part, and this happens in 25% of women. Then
so is it kind of heart-shaped?
I don't know if it's heart-shaped. It's just, yeah.
I've heard of that before.
Then you have the arcuate uterus. I hope I'm saying this right. Looks normal, but the internal surface of the single endometrial cavity shows a shadow groove of 1 centimeter or less. So there's, instead of being smooth and even in the inside, there's a groove. And this happens to 7% of women. Don't laugh when I say this one.
Okay.
Unicornuate. Only half of the uterus develops from a single Mullerian duct. So they get half a uterus, one fallopian tube. And this happens in 15% of women. And then the next is a uterus didelphys. And basically two halves of the uterus develop completely separate. And this happens in 7.5% of the women. And then there's uterus agenesis, where a uterus doesn't form at all. And this is 10% of women with uterine anomalies have this. So it's not 10%. It's just 10% out of all of them. So the two most common ones, like I discussed, are the septate and the bicornuate uterus. So to sum this up, the septate and the bicornuate uterus anomalies are the most common. The arcuate uterus does not have any significant clinical impact and is considered to be a variant of normal. So that's the one where there's like...
just one side?
No, it has like a little groove.
Oh, right. The one with the little lip. Yeah.
Okay. So what causes this? Well, scientists aren't completely sure. But there's one thing that they did see between 1940 to 1971, that generation of women that were born in that time had an increased risk of uterine anomalies. And they believe it's because women were given a drug, an estrogen analog, that was prescribed between 1940 and 1971 to prevent miscarriage and preterm delivery. So they believe that drug had led to that period of time. At least they can pinpoint that it may have been caused, like any of these anomalies caused by that. Another drug that was given during that time is thalidomide, and that's a whole other subject that I'm going to touch on.
Yes.
Okay. So there are no risk factors or preventative factors. So you can't say that if I had this much to drink or if I was overweight, or there's no factors that you're born with it.
Reason kind of thing.
Yeah. Most women have no symptoms Some might have some dysmenorrhea or painful periods, but it's usually discovered when searching for a reason why a woman can't get pregnant. There's infertility issues, or on a routine pelvic exam. And usually what they do is an MRI or a transvaginal ultrasound. Also, too, many women who have these anomalies also have renal defects, okay, like renal agenesis, the absence of one kidney. So that's sort of, or a duplex kidney. So it looks like, it's maybe part of a syndrome. And the treatment is surgical repair or reconstruction. All right. Next, we're going to talk about uterine polyps. These are growths attached to the inner wall of the uterus that extend into the uterine cavity. It's caused by an overgrowth of cells in the endometrium. They are usually non-cancerous, although some of them can become cancerous. They range inside from a small seed to a golf ball or bigger. They attach to the uterine wall by a large base or a thick stalk. And that just... you can have one or many, and they usually stay within the uterus, but they can slip down through the cervix into the vagina. That's a big polyp. They mostly occur in women who are going through or have completed menopause, but some younger women can get them. So what are the symptoms? If it's premenopausal, you can have irregular menstrual bleeding, frequent unpredictable periods, or different lengths of periods and heaviness. Bleeding between menstrual periods, excessively heavy menstrual periods, vaginal bleeding after menopause, and infertility. And some women have no symptoms, same as before, or mild ones like spotting. But if you are postmenopausal and you're spotting, you need to see the damn doctor immediately. Causes. Hormonal factors. Uterine polyps are estrogen sensitive, so they grow in response to circulating estrogen. Risk factors. Being perimenopausal, postmenopausal, hypertension, obesity, again, taking tamoxifen for breast cancer treatment. It's diagnosed through a transvaginal ultrasound, hysteroscopy, and endometrial biopsy. And they want to do that to send off to see if there's any precancerous or cancerous tissues in there. So the treatment, watchful waiting. Small polyps sometimes resolve themselves and don't need to be removed unless there is a risk of cancer. Medication. So hormonal medications like progestins, like we talked about, the GRHA, that lessen symptoms. But it's not good to take it long term. Again, because an excess or too much or too little of these hormones can cause wreak havoc on a woman's body. And then polyps will return after, and the symptoms will return after this medication stops. So this is sort of like an in-between sort of treatment to see what happens. Of course, you can have surgical removal and then a biopsy done. And if it is cancer, then you're going to start a cancer treatment discuss it with your physician. And on that note, the last thing we're going to talk about today is uterine cancer. So there are two types of uterine cancer. Sometimes they're said in together, like it's, interchangeably, like it's the same thing, but it's not. So endometrial cancer, it develops in the endometrium. And it's the most common of all gynecological cancers. And then the second one is called uterine sarcoma, and that's in the myometrium, the muscle of the uterus. And but this is incredibly rare.
Yeah, I was going to say, which one's more dangerous? Like a sarcoma to me is always like, ooh, that's not good.
Oh, they're both quite dangerous, but yeah.
Well, just because endometrial tissue generates like every month, right?
Yeah, but it also can cause these cells to grow and multiply, right? So risks. You've got your usual suspects here. But so something that causes an imbalance between estrogen and progesterone, age after 50, diet high in animal fat, family history, diabetes, obesity, ovarian diseases like PCOS, early menstruation before 12, late menstruation, late menopause after 50, long menstruation, the length of it. So it's kind of the same thing. If you got it when you were 12 and then you had it until you were 50 something, like that's like 40, 50, like 45 years of
hell.
Not getting pregnant due to the increased exposure to estrogen. Early radiation therapy in the pelvis for another cancer. Estrogen replacement therapy. You need to talk to your doctor about that if you want to know if it's worth it for you. And tamoxifen, the breast cancer treatment. So the symptoms: vaginal bleeding between periods, vaginal bleeding or spotting post menopause. Go see your doctor. Tough old broads. I'll be fine. Lower abdominal pain and cramping, a thin, white, or clear vaginal discharge post-menopause, extremely prolonged, heavy, or frequent vaginal bleeding if you're under 40. Diagnosis: physical exam, pelvic exam. Also the CA 125 blood test that determines the protein level, how much is being broken down and released into your body. And the number is less than 46. Imaging tests, CT scans, MRI, transvaginal. Other tests would be an endometrial biopsy, hysteroscopy, DNC, also for a biopsy. So the type and stage of your cancer equals the treatment that you will get. So type 1, it's less aggressive, usually doesn't spread. Type 2 is more aggressive and is more likely to spread outside of the uterus and may need a stronger treatment. Then you have stage 1, hasn't spread. Stage 2, it's into the cervix. 3, it's spread into the vagina, ovaries, or lymph nodes. And stage 4, it has now spread into the bladder and metastasized to other areas of the body. So for instance, if you had stage 1, type 1, you have a good chance of recovery. So the treatments are chemotherapy, radiation, hormone therapy to increase or block certain hormones, immunotherapy, you want to boost the immune system, and targeted therapy where they go after very specific cancer cells. And then surgery, total hysterectomy, vaginal hysterectomy, or a radical hysterectomy. So some people think a total hysterectomy and a radical hysterectomy are the same, but they're not, because a radical hysterectomy removes the uterus and tissues next to the uterus. The top part of the vagina that is next to the cervix. So that's massive surgery. And or you may have a minimally invasive hysterectomy, depending on how advanced it is. And along with that, you can also maybe get a oophorectomy, removing one or both of the ovaries, and lymph node dissection. The survival rate is 5 years, 81% survival rate. But say the type 1 stage 1 is 95% in 5 years. They usually only give like the 5 year. It doesn't mean you're going to die after 5 years. It just means that they can pretty much say that is the survival rate to that time. So. So that's the episode today on the uterus.
A complex organ.
Now, I know we made some jokes and stuff throughout the thing, but, women's, disease of our reproductive system, I mean, it's a major part of our existence, of our living, and lots of things, like I said, can go wrong because it's so complex, and the hormones are so significant, so powerful, that a lot of things can go topsy-turvy to the point of also being very serious to our reproductive system. And we have to keep a close eye on it. So, women historically don't want to go get help for reproductive issues because, it's just a woman thing and they're being emotional and that's just life and just suck it up and everything like that. No, these are very serious things and you should not have to live with suffering if there are treatments for it.
Yeah, for sure. And like I said, some women just think that having a very painful, heavy period is normal because, they're family. Everybody's like that. But that's not.
It's just part of life, It's just
not the norm, right? To
it
have
isn't.
a really heavy period so you're anemic, to the point where you're anemic.
Or, like you said, you shouldn't have to take Percocet for something that's supposed to be normal and natural. So, ladies, let's get our regular checkups. Let's talk to our doctors or nurse practitioners, gynecologists, if things do not seem, within the norm. Take care of yourself. Take care of your bodies. Put that first. Put that ahead. I know it's hard when you have a family. I know it's hard in this busy life that we live, and with all the things like COVID that have made it difficult for us to see our doctors or get in. But, please don't let your health, especially your reproductive health, where things can be dismissed or overlooked. Take care of yourselves, ladies. We love our ladies. We love our moms and our aunts and our best friends and, sons and grandsons and husbands and friends. They love you too.
And wives.
And wives. That's right. Okay? So that's how I'm going to end this note. Next Women's Health episode, we're going to be talking about fallopian tubes and ovaries. But the uterus, she's a big bitch. A lot of stuff to talk about.
She gets her own episode.
I'm part of another one, the one before it.
Right, exactly.
Okay, so I hope you guys are doing well in this crazy, crazy world that we live in with all this stuff going on. But remember that you're amazing and there are also really wonderful things happening in this world. And to take care of yourself, take care of one another, and most importantly, love yourself.
Peace.
One love.
True crime and it gets none realer. Sometimes it'll be the cure that'll kill ya. Gotta watch out, yeah, you gotta watch your back, cause you don't wanna be another episode on Stat. Thank you for tuning in, learn a thing or two. These medical mysteries can be unbelievable. Yeah, subscribe, make sure you do that so you'll be tuned in and be ready for the next show. Stat.